Hello, everyone. Thank you all very much for coming. It's my pleasure to welcome you to our webinar series, What to Expect, A Guide to Prostate Cancer. My name is David James, and I'm the Head of Patient Projects at Prostate Cancer Research. This webinar series is a collaborative project between ourselves and the pharmaceutical company Ipsen. Now, today we have the 7th of our webinars in this series, and this today is Metastatic Prostate Cancer Part 2. Now, today we're joined by oncologists Ian Sayers and Joe O'Sullivan. Now, as I mentioned, today is the second of our 2 webinars on metastatic prostate cancer. Last week, we looked at metastatic hormone-sensitive prostate cancer, while today we're looking at metastatic castrate-resistant prostate cancer in more detail. And now in our final webinar next week, we'll be talking about prostate cancer and end-of-life care, including the emotional, spiritual, and mental aspects of end-of-life care and the planning it may require. And just a reminder, if you've missed any of our previous webinars, don't worry, because all of these can be watched on demand on our website, www.pcr.org.uk/what-to-expect. And just a reminder, for the purposes of today's presentation and for simplicity throughout, we've used the term men, but this should be considered to include not only men, but also trans women, non-binary people who are assigned male at birth, and some intersex people as well, as they're also all affected by prostate cancer. Now today, as I mentioned, we're looking at metastatic castrate-resistant prostate cancer, including how it differs from other types of prostate cancer and the current treatment options. We'll also be exploring some of the potential side effects before delving deeper into possible future treatment options, including research and clinical trials. Now over to our first speaker.
Hello, my name is Dr. Ian Sayers. I'm a consultant clinical oncologist working at New Cross Hospital in Wolverhampton. I specialise in prostate cancer. I want to talk today about castrate-refractory metastatic prostate cancer. I want to talk about what that is and some of the treatments for it. I want to talk about why some treatments are used instead of others, how good those treatments can be, and some of the side effects of those treatments. So, what is metastatic prostate cancer? This is defined as cancer that can be found outside of the prostate or the lymph nodes around the prostate. Usually we refer to this as cancer that's outside the pelvis on standard scans. There are more modern scans available that can find small deposits of cancer elsewhere in the body, and the significance of this is a little uncertain. Prostate cancer usually needs androgens in order to survive and grow. The most common androgen and the most potent androgen in the male body is 5-hydroxytestosterone, but it's not the only androgen in the body. The fundamental basis of treatment for prostate cancer is either cutting off or suppressing the supply of androgens to it. Historically, this was carried out with surgical castration, although from the 1970s and 80s onwards, drugs were used to lower men's testosterone levels, which proved to be nearly as effective as surgical castration. And they're now the most common treatment for prostate cancer. Initially, these treatments will work even against aggressive prostate cancers. However, if a prostate cancer isn't defeated this way, then eventually it will become resistant to it. Metastatic castrate-resistant prostate cancer is where a prostate cancer has grown through the treatments used to lower a man's testosterone level to so-called castrate levels. There isn't universal agreement about what castrate levels are. However, it's certainly below 1.7 nanomoles per litre, and some would argue that it should be below 0.7 nanomoles per litre. When prostate cancer grows through androgen deprivation therapy, which is the correct name for what we often call hormones, then there'll be a number of signs, the most important of which is the PSA rising, despite the fact that the testosterone is in the so-called castrate range. You can also get clinical symptoms of worsening prostate cancer, which are typically worsening bone pains, worsening problems going to the toilet, problems eating and maintaining your weight, doing less and feeling more tired. If you get these symptoms together with a rising PSA, then we would usually request scans, either an isotope bone scan and a CT scan, or sometimes a PMSA scan, in order to look for signs of the cancer spreading around your body. If a prostate cancer isn't defeated by the initial treatment, which is either surgery or radiotherapy with or without hormones, then eventually it will grow through hormonal treatments. So when somebody's cancer progresses despite the fact that they've either had injections to lower their testosterone level or they've had their testicles surgically removed, surgical castration, then we describe it as castrate-resistant. One of the questions that often gets asked is whether you should continue the injections or not. We usually do continue the injections because we would be quite worried about the effects, if we remove them, of other parts of the cancer that are controlled. We can add further drugs to try and control the cancer by manipulating the hormonal environment. A moment ago, I talked about the fact that testosterone is not the only androgen in the body. Androstenedione is produced by the adrenal glands, and one of the medications that can be used reduces the amount of androstenedione in somebody's body. I also mentioned that so-called castrate levels aren't zero levels of androgens. Tumors which have grown resistant to hormonal therapy can make use of very small amounts of testosterone to continue to grow. Therefore, the two types of tablet-based therapy that can be introduced to try and control a prostate cancer once it has grown through injections can either reduce the amount of androstenedione in a man's body, or they can get much better at blocking the effects of all androgens at the androgen receptor. There are more modern forms of anti-androgens, so-called second-generation anti-androgens, that work better than the older drugs. These treatments won't work against all cancers, only cancers that still have some dependence on the so-called androgen pathway. If your oncologist thinks it's right for you and your cancer, they may not suggest these tablet medications, but they may decide to treat you with chemotherapy first. Or your cancer may grow through the tablet treatments that are being prescribed or grow back again after they have worked for some time. At that point, chemotherapy is usually considered for men fit enough to cope with it. We would usually say that anybody up and walking around more than half of waking hours is fit enough for chemotherapy, as long as they don't have other medical conditions that would make it more dangerous. Radiotherapy is often given at multiple points during the care of a patient with metastatic prostate cancer. It can be given if you've lost control of the prostate cancer, for example, if the cancer grows in the bones, and it's particularly important if it grows in the spine. Specialized forms of radiotherapy include stereotactic ablative radiotherapy, which is being investigated for treating small volumes of cancer growing while patients are on other treatments. While it's not yet a standard of care, it is something that people are very interested in providing for patients, and it seems likely this will become increasingly important in the future. Radiotherapy can also be given using radioisotope treatments. That will be discussed later. Steroids have been used for a long time to control prostate cancer that isn't responding anymore to the injections to reduce a man's testosterone level. Steroids, unfortunately, do cause some side effects, such as weight gain and bruising of the skin, as well as making diabetes worse. Sometimes the side effect of causing somebody to put on weight can be useful for treating a patient. Bisphosphonates are drugs that can either be given as an injection or as a weekly tablet to try and improve the density of the bones. This is particularly important for men who've been on injections for a long time to lower their testosterone, as they'll often have an element of reduced calcium level in their bones. Your oncologist will recommend you to have a bisphosphonate with or without calcium supplements if they think you're at risk. Other treatments often given to prostate cancer patients include painkillers such as opiates and paracetamol, and sometimes non-steroidal drugs such as ibuprofen or stronger versions. Nutrition is also very important in prostate cancer patients, although the important thing is that somebody has a balanced diet with adequate calories for what they need. Thank you for listening to this.
Thank you very much. We're going to hand over to Joe now. Joe, over to you.
Sure. Thanks, David. Yeah. So my name is Joe O'Sullivan. I'm a prostate cancer oncologist based here in sunny Belfast, although I'm speaking to you today from the wilderness of Sweden. So nice to see you all. I'm going to first of all tell you about how to understand and manage the side effects of treatment. So Ian has told you very clearly the type of treatment approaches that we have in metastatic castration-resistant prostate cancer. And I will tell you a little bit about some of the side effect profiles that you can expect. So next slide, please. So first of all, chemotherapy. As Ian said, chemotherapy is often used in the treatment of men with metastatic castration-resistant prostate cancer. And chemotherapy, as you might well know, has a lot of different side effects that can affect patients. I think the most important side effects are the ones which are potentially life-threatening. But the very important, I think that probably the most important thing, and when I'm counseling and consenting patients for chemotherapy, I'll let them know about the potential dangerous side effects first, and then move on to the less serious ones. So I'll do the same now. The most serious side effect really is a drop in the white cell count. And white cells are the blood cells in your body which protect you from infection. And when you've had chemotherapy, you can expect your white cell count to drop, usually at about 7 to 10 days after the chemotherapy has been given. If the white cells drop and you were to pick up a bacterial infection, like for example, a chest infection or a throat infection or a urinary tract infection, while the white cell count was very low, that can be very serious. And the condition is called neutropenic sepsis. Neutropenic sepsis is really a medical emergency. And so patients receiving chemotherapy are usually given quite a lot of information, a 24-hour helpline number to call if they feel unwell while on chemotherapy, because one of the serious side effects can be this neutropenic sepsis. For patients who develop this side effect, they really need to be admitted to hospital and treated with quite strong intravenous antibiotics. Other side effects of chemotherapy include breathlessness and fatigue, and most patients really feel quite tired the day after or maybe 2 days after they receive chemotherapy. Other side effects that can happen also because of other blood cells which can reduce, which are the platelets. They're the ones which help your blood to stay clotted and help your blood to clot if you have a bleed. So sometimes bleeding and bruising, or very easy bruising, can happen as a result of chemotherapy. Typically, some patients can feel sick or nauseated, although I think we really are much better now at treating chemotherapy nausea. So along with the chemotherapy, most people will receive very strong anti-sickness drugs in the form of intravenous injection, as well as some tablets to take home as well. Some patients find, especially with the type of chemotherapy used in prostate cancer, that they get a funny taste in their mouth, a metallic taste. And for some people, this can change how they taste coffee or tea or wine. And some patients will find every food tastes a bit like salty, or every food tastes like cardboard. So it's not a very nice symptom. There are some ways to manage that. And the other thing that can happen is other fast-growing tissues within the body, that's the hair, the nails, the lining of the guts, can be affected. So quite a lot of patients will experience the nails can get quite changed, streaks across the nails. Sometimes the nails can get a bit completely white or gets white streaks across there. And the bowels can affect, you can get diarrhea. And in fact, diarrhea can be quite serious as well if left untreated. Typically, most men will lose some hair with chemotherapy. It's a bit variable. So I normally advise getting a short haircut at the start of chemotherapy. Other symptoms that can affect men would be fluid retention, so maybe swollen ankles and a bit of breathlessness, and sometimes numbness or tingling. Just next slide. Yeah, there we go. So Also, so steroids, Ian also mentioned that steroids are used both along with chemotherapy as a protective treatment, but also as a treatment in their own right. It can sometimes be quite a good treatment to alleviate symptoms, especially further down the line in metastatic castration-resistant prostate cancer. Typically, steroids cause increased appetite. They can cause weight gain. Some patients can get a bit puffy around the face and around the belly area. And sometimes it can irritate conditions like diabetes. If a man is sort of on the edge of diabetes, sometimes it can push them into that condition. And if you're taking steroids for a long time, it can also affect the bones, and it can cause, it can make osteoporosis a bit worse. So there are a number of different things to deal with that. The steroids can cause irritation of the stomach, like an acidic or a feeling like indigestion. So taking steroids after a meal can help, and sometimes taking tablets that can reduce the acid in the stomach. The appetite is more difficult, but I tend to recommend that whoever does the shopping in the house is very careful not to buy lots of sweet things, because for sure the person on steroids will find them and eat them. So I think you have to be clever about what's in the house and what's available to eat, and try to be a bit disciplined, particularly with sweet things and carbohydrates like pasta, potatoes, etc. Just to be a bit more control with that. Being more active in the mind and fluid retention, they're all more difficult to manage easily, but if you do talk to your doctor or your nurse, they should be able to help with those type of symptoms. As Ian correctly said, weaker bones, generally, we think this is a big problem in prostate cancer generally, so you may need to take supplements like calcium or vitamin D, or you may also need stronger drugs like bisphosphonates. Next slide, please. And very important not to stop steroids quickly. Another treatment that Ian mentioned is internal radiotherapy or radionuclide therapy, or using radioactive drugs which can be injected intravenously into a patient. And the only drug currently available is radium-223, but I will tell you about another agent that's on the horizon soon towards the end of the talk. Radium-223 has been around for almost 10 years. It's a drug which is like a bone-seeking missile. If you inject this drug into a patient's veins, it will behave like calcium. It will circulate around the body and then sticks in the bones, and especially sticks in the bones where the prostate cancer is. So this is for patients where the cancer has spread to the bones, which in fact is really the vast majority of men with advanced prostate cancer will have bone metastases. It's not really effective in men where it's spread to other parts of the body like the liver or the lungs. So it's really for men with bones only. The side effects tend to be fairly mild overall. You do get some drop in blood counts, especially the ones that might cause bruising or bleeding, the platelets. It can cause diarrhea, sometimes nausea, but in general, these symptoms are fairly mild. The diarrhea can be easily treated with drugs like Imodium over the counter, and the feeling and the sickness and the nausea can also be treated with antiemetics or anti-nausea drugs. Next slide, please. These drugs are normally given as an intravenous injection once every 4 weeks for six months in total. Now, probably in prostate cancer, the drugs that cause the most side effects and that are used in pretty much every single patient are hormonal therapies. Whether that's castration therapy, drugs designed to lower the testosterone. They tend to have fairly similar side effects: hot flushes, like menopausal type symptoms, sweating, weight gain, some swelling or tenderness around the breast area, and for sure, reduced sex drive. Pretty much universally, men where the testosterone is lowered, and also men receiving drugs, are likely to have a very, very low or indeed non-existent sex drive. So I think it's very important. I always try to counsel patients before they start these treatments what to expect, because it's not very nice if this symptom comes on you and you weren't really expecting it. And I think it's important if the patient has a partner or significant other, that they're involved in those discussions as well and understand, that it's the drugs causing this drop in sex drive. And I think that's important to state at the start. Next slide, please. I think dealing with things like erectile dysfunction can be very challenging in the advanced metastatic castration-resistant prostate cancer setting. However, I think it's very important that patients are given the opportunity to talk about this, to understand that the reduction or the absence of their sex drive is because of the drug therapy, and that their partner understands this. Also that there are some treatments available. For example, there are some treatments which can help patients at least achieve an erection, whether drugs like Viagra or Cialis can help. Sometimes other therapies and other treatments can help get and maintain an erection. But of course, it's also important to understand there are other forms of intimacy, and sometimes it's good to have a very open chat. And ideally, a specialist nurse with experience in this area is the person to talk to. But I think it's very important not to ignore this issue, and for sure talk to your oncologist or urologist about these symptoms if you're worried. Next slide, please. So that's a very quick run through the side effects. And I guess we tend to talk about how well drugs work, how much they lower the PSA or help men live longer. But I think it's important to have that discussion, the pros and cons of therapy, because particularly if the side effects are something that somebody is not willing to take or willing to put up with, I think they really have to have the option of not having that therapy. And when consenting somebody for a treatment, I always say to them, look, this is a treatment option. You don't have to have it. Here are the potential side effects. Here is the potential benefits. And you have to weigh these things up like you do with other decisions. And of course, the doctors and the nurse specialists can help with those discussions. So getting into the final section, just check the chat to make sure I'm on the right track here. So getting into the final section of the talk, really this is focusing on what are the treatments on the horizon and how do we understand these treatments and how do we develop these treatments? So next slide, please. And it may be that when you come to have a discussion with a doctor or your oncologist or urologist about your next treatment option, one of the options might be taking part in a clinical trial. Now, clinical trials are basically experiments, but unlike in a laboratory setting, these experiments are done on real life people. So a clinical trial is a type of research study which involves human beings taking part. There are different types of clinical trials, and they can answer different types of questions when it comes to assessing new treatments. For example, is the new treatment safe? What are the side effects? What's the correct dose? How many times a day should the tablet be taken, or should it be given as an intravenous injection? So many of these issues are sorted out in a clinical trial. We have different types of clinical trials, starting with early phase or phase 1 trials, and they tend to be the trials that tell us how safe a drug is, what's the correct dose to use, for example. Then phase 2 and phase 3 trials, that's really when you're trying to find out how effective is this drug? How does this drug compare to the currently available therapies, or indeed it could be a combination of drugs. So they tend to be phase 2 and phase 3 trials. And the phase 3 trials especially tend to be randomized. Next slide, please. And these really are, and in fact, the UK can really hold its head up high when it comes to clinical research in prostate cancer. In fact, when I travel around the world, going to various conferences, the UK really has made a massive contribution to the understanding of prostate cancer through clinical research. So we've got a lot to be proud of in this country. So if you're offered the opportunity to take part in the clinical trial, there are pros and cons, of course. I think, first of all, you will be certainly given lots of information, hopefully time to discuss that information, have it explained to you properly by a research nurse and by the clinician running the trial. You'll also be given information to take away. And normally, and very importantly, you need to be given time to think about these things. So I never rush patients into clinical trials. I like to give a minimum of 24 hours, but ideally at least a week, for people to discuss with their family, is this right for me? And also maybe discuss with their own general practitioner if possible. So why do people take part in clinical trials? Well, it may be because they get more medical attention. For example, you get more regular checkups, more support. There's a research team looking after you as well as the clinical team. I think many people enter clinical trials because of the potential of getting new drugs that are in development. A new drug doesn't always mean it's the best drug, but I guess if somebody has run out of treatment options, or at least run out of treatment options that they're willing to accept, then a clinical trial may offer the opportunity of trying something new. Now, there may be some downsides. Again, perhaps because there are more scans involved and more blood tests, etc. It might be quite cumbersome. Some clinical trials can involve a lot of extra blood tests and And that can be tough for some people, depending on their lifestyle and their other responsibilities. Of course, a clinical trial is testing a new drug. We don't know if it works well enough. It may not work. So it may be possible that you take part in a clinical trial, have lots of extra tests and scans, and then the treatment doesn't work. That is surely a downside. And also there may be unexpected side effects, because with the drugs that are already established, the reason they're already established is they've been through this testing process. We understand better the clinical or the likely side effects. But in a clinical trial, you can get unexpected ones. Some people, especially with a randomized trial, that's where a computer decides whether you get the new treatment or the standard treatment. Sometimes it's called a placebo-controlled trial. So you and your doctor may not know whether you're receiving the new drug or whether you're receiving a dummy drug. And this is in order to do the trials properly. So that can put some people off clinical trials. However, really it's the only way to test new drugs in a clinical trial, is to do placebo-controlled in some circumstances. Next slide, please. So that's clinical trials, and I think very important that you ask your doctors and your nurses about whether a clinical trial might be right for you. I think especially if you're running out of treatment options, or as I said, running out of treatment options that are acceptable to you in terms of side effects, etc. But because of clinical trials, we also know what the next drugs on the horizon look like. Now, these are drugs which have been around for a while in ovarian cancer and breast cancer, and are just starting to be available in prostate cancer. And they're drugs that work, and it's only a particular subset of men that these drugs really are suitable for. And it's men with a particular type of mutation in their cancer cells. And these are mutations which reduce the ability of the cancer cell to repair damage to the DNA. DNA is the genetic blueprint of the cells. And DNA really is, I suppose, the heart and soul of these cells. If you damage the DNA, the cell generally dies. So some patients, about maybe 8 to 10% of men with advanced prostate cancer have mutations in their DNA, which mean that these particular drugs called PARP inhibitors can work well. They're normally taken as tablets. They're not free of side effects. They can cause some blood count drops. And you may have heard of a mutation, a DNA mutation called BRCA. And BRCA1 and BRCA2, these are genes which can be mutated in men and also women with breast cancer. They tend to be mutated in patients who have a strong family history of prostate cancer, or a strong family history of younger women with breast cancer. So for example, women under 50 or men under 50 with serious prostate cancer within the family circle. So PARP inhibitors are certainly coming. About maybe 8 to 10% of patients may benefit. In order to see if you're suitable for a PARP inhibitor, you either need a special blood test, but usually you need to analyze the original biopsy of the prostate gland. Now, a treatment, another radioactive treatment, which is on the horizon, something I've been working with for many years, radioactive therapies, and you may have heard of lutetium PSMA. So lutetium-177 is a radioactive chemical. It's stuck onto a molecule called PSMA-617, which actually is a drug, which is a peptide, a very small molecule, which if you inject this drug intravenously into a patient, it circulates around the body and it sticks to something called PSMA. Now, PSMA is prostate-specific membrane antigen. This is a little protein that sticks like an antenna on the surface of a prostate cancer cell like this. It sticks up like this. It passes through the cell, the sort of wall of the cell, and there's a bit that's visible. So when the drug is circulating around the bloodstream, it sees this thing called the PSMA and sticks on. And when it sticks on, gradually the actual molecule, this lutetium-177, this radioactive drug, is pulled into the cancer cell, and the radiation that emanates from this drug damages the DNA of the cancer cells. What's good about this therapy is that PSMA, this protein that sticks out of the cell, is really mostly present in advanced prostate cancer cells. It's also present in the salivary glands, the ones that give you that create your saliva, to a small degree, sometimes in the guts, but by far and away the most common cells in the body that have this little antenna sticking out are prostate cancer cells. So it really is a way of targeting the prostate cancer cells, delivering very powerful radiation to those cells. So you may also have heard of immunotherapy. Now, immunotherapy is basically drugs which stimulate the body's immune system and turn the immune system onto the cancer cells. So this is an idea that's been around for a very long time. And it's only really in recent years that immunotherapy has been shown to work, especially in cancers like melanoma, that's the really bad skin cancer, lung cancer, and some breast and ovarian cancers. So immunotherapy is being tested widely in prostate cancer, and these drugs are being tested along with other drugs like chemotherapy, hormonal therapies, and also radioactive drugs. First of all, metastatic castration-resistant prostate cancer means prostate cancer which is spread to other parts of the body, almost always the bone, but can also be the lung and the liver, and that is no longer responding to the reduced level of testosterone that we call castration. So castrate-resistant metastatic prostate cancer. It's definitely the most serious part of prostate cancer, and it's the one, thankfully, there are several drug therapies to help extend life, but there are no curative treatments as yet in this setting. I think many of the treatments that already described are widely available in the UK, and clinical teams are well experienced using these drugs, explaining the side effects and explaining the benefits of the therapy. I think ongoing research is absolutely crucial. Without clinical research, we will make no progress in treating this cancer. Consider clinical trials, especially when they're faced with the situation of running out of treatment options. So I'd strongly advise patients to at least ask the question, are there clinical trials potentially available? So with that, I'm very happy to end my part of the discussion.
Thank you so much for that, Joe.